Hi, thank you so much for coming today. I'm very excited to be here. I am currently an assistant professor in the Department of Kinesiology in the Occupational Therapy program. But before I began my journey on higher education and research, I practiced as an occupational therapist for many years. And if I reveal how many, it'll give away my age, so I'm not going to. And I was the director of an interdisciplinary feeding clinic in California, in the Los Angeles area. And that experience really helped shape my research questions and my research agenda. And I feel like I bring a lot of that practice experience into how I'm hopefully executing research today. So this is particularly meaningful to me to speak at this conference today. So today we'll be talking about eating and mealtime challenges for families and children with ASD. So we're going to start today by doing a little bit of an overview of some of the challenges that are reported in the literature. Then we're going to spend just a brief period of time talking about an assessment that we've developed to hopefully better characterize feeding challenges in children with autism. And last but not least, we're going to give an overview of a parent-mediated intervention that we're currently piloting right now, and some very preliminary results. So, and excuse me, I'm hopefully getting over a cold, not starting one. Disrupted feeding patterns have been around for a long time and have been described in some of the earliest literature when talking about families and children with autism, all the way back to Leo Kanner's original descriptions. He talked about the challenges that families were having or reporting with regards to their kids' eating patterns. We know that it's a very prevalent problem for children with autism, that up to 89% of kids with autism are reported to have some kind of disrupted feeding pattern. Now that prevalence is difficult to interpret because, as with autism, feeding challenges are highly variable in different families. So when we think about reporting prevalences and describing feeding challenges, is it related to selective eating behaviors? Is it related to behaviors at the table? Is it related to a simple refusal to eat? There's all kinds of different ways that these feeding challenges manifest, so the prevalence is difficult to describe. And that is one thing that we're also hoping to undertake in our research lab, is finding better ways to characterizing feeding challenges in children with autism. And if we can do that, hopefully we can find better targeted ways to intervene as well. However, we do know that kids with autism are 5 times more likely than their typically developing peers to have feeding difficulties. So it is a significant problem. And because of the types of challenges that do manifest, it does have significant effects on medical, developmental, and social outcomes. And there's a large body of literature that's starting to associate different feeding difficulties with some of these other areas of outcomes. So feeding characteristics are not a core challenge of autism, but probably one of the most commonly associated characteristics. And as you can imagine, they're highly related to core symptomology. So if you think about an increased sensitivity to foods and sensitivity to feeding environments, and combine that with ritualistic behaviors, you can think about how that can contribute to increased food selectivity and aberrant feeding behaviors. And there are some studies that are suggesting that higher restricted and repetitive behaviors are more likely tied to increased selectivity in diets. And when we talk about feeding difficulties with children with autism, we consider that any difficulty that interferes with proper nutrition intake, food acceptance, appropriate mealtime interactions, and family routines. So you think about that, that's a pretty wide spectrum, and that can relate to underlying health challenges. And a common example for that might be if a child struggles with constipation, chronic constipation, that really limits their interest in eating, as well as their hunger satiation patterns, as well as a very restricted diet, or even overeating preferred foods like snack items. So when we think about feeding, based on what the literature tells us, as well as what we're uncovering in our research lab, is that we think about disordered feeding really having 4 primary reasons that contribute to the disordered eating patterns. So sensory processing, general behaviors, oral motor dysfunction, underlying health conditions, and as we all know, there isn't much feeding that goes on outside of a social context. So we would think about all these things being embedded in a broader social context. And that social context could be at home for meals, it could be for breakfast, school, birthday parties. As we think about, there's very few opportunities or social engagements that we participate in that don't involve food. Even this morning, what did our resource fair involved? Snacks. So it's really important to think about not only the underlying things that we contribute to the disordered feeding, but also the social context in which they occur and who those other social players are. So we're going to now talk about each one of these a little bit more about how they're just being described in the literature. And one more thing about this. Although it feels very simple, the child has a very selected eating repertoire. They only eat hard, crunchy foods that are white. Okay? It's very unusual that there'll only be one cause or challenge of a feeding challenge, right? So that child, although may be very, very selective in what food they choose to eat, may also be struggling with chronic constipation. And so there's often multiple reasons why we might see a child have difficulty eating what we would consider a health-promoting diet and what we would want as far as the different social contexts. So it's usually not just one thing or another, but we think about these things as co-occurring. So sensory processing. This is the most common reported challenge in children with autism and feeding difficulties. However, sometimes I wonder if that's just what we see first, whether some other things might be equally as common, but this is what often is first reported by families. And what we mean by that is any kind of variable perceptions and responses to food properties. And we can think about the smell, not being able to be in the same room as other food is being cooked, taste, texture, just the visual presentation, that ongoing concern that how do you know if you like it? You haven't even tasted. Where kids make a decision just based on the visual properties of the food that it is not going in their mouth. And you can't make them. So for those who have been told, just wait it out, it doesn't work. And also temperature. Some kids are highly, highly sensitive to temperature. And often you might have a combination of these things. And sometimes what seems to be the most frustrating for families or interventionists is that might not always be consistent. So the child eats primarily simple pureed foods. However, at one cafe with their mother, they will eat a croissant. Okay? So it doesn't mean that the sensory processing isn't contributing to their food choices. It means that they've established one rule or exception to what that is. And that's great, because then we can build on that, and I consider that a strength. Often there's a general food selectivity, a texture selectivity, or a general food refusal based on those sensory properties. It has been shown that kids with autism do generally eat a narrower variety of food, even when they're toddlers. When many children are going through picky eating phases, they do tend to eat fewer foods during that phase. And you'll also see kids seek out certain foods with sensory properties, such as crunchy or chewy, and eat for the sensory reasons even more than for the nutrition reasons. And sometimes that becomes difficult because they don't have a really good sense of satiation, so they never get full. So they'll keep eating until you actually put the food away. Kids will get very stuck on certain textures or flavors, and if you present them with unpreferred textures or flavors, it'll induce gagging, vomiting, and pretty significant behavioral responses to try and protect themselves from eating those foods. When we're thinking about sensory processing, we also need to remember the sensory environment, and that could include the other social people in the environment, so siblings. A common report is they can't tolerate the chewing of other people at the table. It might also be the sensory environment, particularly in school or social settings, all the sensory chaos that occurs in a cafeteria, to at home in the evenings. Some kids are sensitive to the other appliances in the kitchen environment, so refrigerators, even stoves on and off, dishwashers, things like that. So make sure when we think about sensory processing, we're not only thinking about the child, but as well as the other sensory players and the environment in which it's occurring. Oral motor. I think this is the greatest overlooked area for our kids, that they have some oral motor dysfunction that often may be hidden under behaviors or sensory behaviors. So kids can have delayed oral motor skills or a general dyspraxia, and sometimes they haven't had the opportunity to be able to develop those skills because maybe they were very hypersensitive and never went through a mouthing phase. Okay? Maybe they transitioned to dissolvable solids and never went through chewing. So they just haven't had that opportunity. Sometimes it's part of an overall motor delay, which we might hear a little bit more about later. But kids having delayed oral motor skills can really help shape what foods they're willing to eat, how they manage those foods and maybe behaviors they put up to protect themselves from eating foods that they aren't able to efficiently manage yet in their mouth. Sometimes this can result in really prolonged meal times because kids chew and chew and chew and chew and chew and chew forever before they swallow, or simply refuse to eat certain foods of certain textures. And then it's really confusing because is it based on a texture issue sensory-wise, or is it because they just don't have the skills to manage some of those more complex foods yet, or it just takes too long. Another area that's really important when we think about feeding challenges is health. And there is a pretty significant body of literature now that is showing that allergies and gastrointestinal dysfunction do have a higher prevalence in children with autism. And I just want to be clear, when I'm saying this, I'm suggesting that there's a higher prevalence, but I don't think we've had research yet that has come out that supported any special diets to support these difficulties, but just the general allergies and GI dysfunction, for example, like constipation. It often can show itself in gas, bloating, diarrhea, constipation, abdominal pain, vomiting, food sensitivities, which are different than allergies, right? So an allergic reaction is an anaphylactic, hives, difficulty breathing, versus an insensitivity, which may have some diarrhea or discomfort, and pain with stooling. And for those of us in the audience, we can't talk about eating without talking about stooling, and for anybody who's being constipated for over periods of time, it doesn't feel good to eat. And so making sure that we're thinking about addressing some of these underlying GI issues simultaneously, or maybe as the primary cause for some of the feeding difficulties, is really important to think about. And because some of the children don't yet have the ability to communicate with us in a way that we understand, or to be able to fully express the discomfort they're in, we kind of have to be detectives to figure some of this out. So we have to make sure, if that is an underlying concern, that that's addressed in correlation with other kinds of interventions. So also related to health is selective diets and nutrition, which is a common question. And kids often eliminate entire food groups, no one's surprised, fruits and vegetables, or have an excessive intake of snacks or processed foods. So eat bags of veggie sticks, okay? So not just a large portion, but bags. And that becomes one of their primary caloric contributors. And so that's important to think about, is when the diet is full of so much of one food. And that's why things like 3-day diet records are really important to think about, not only to tell how many calories a child is having, but to think about what are the eating patterns. So even though they might eat a chicken nugget, they'll only eat one, and really most of their calories are coming from these more processed snack foods. So, and often these can be associated with other medical concerns, such as obesity, osteopenia, and constipation. And again, this is a new body of literature that's coming out. The big question is then, how does this affect children's growth? And the literature is still inconclusive on that, and I think we'll find out in a few years on what we think that it does. So a recent meta-analysis that Sharp and colleagues did suggests that they didn't think that it did have a long-term effect on growth. However, 2 or 3 other research groups that have come out had said, yes, when you look across all the studies, but when you look at specifically for certain groups, particularly designated by race and ethnicity, or other co-occurring conditions, or at certain important developmental transitions, it does have a significant effect on growth. So hopefully, as we move forward in our research, specificity improves, we'll be able to tell who and what kind of diets are really impacting long-term growth. So I'm going to jump so we get to talk a little bit more about some of the research we're doing. Behaviors, our belief is that behaviors are often a consequence of other underlying challenges. Our kids don't decide, I'm going to be difficult today, so I'm not going to eat the food you want. Usually it's because they have a sensory issue, an oral motor difficulty, or some underlying health challenge, or coupled with some of the rules and rigidity that they've created around food and eating. And we all know how this can develop, or how this can manifest with tantrums, aggression, refusing to eat, throwing, spitting food. That becomes particularly challenging when they have siblings, and families are very worried about their siblings starting to imitate the feeding behaviors, both the food selectivity as well as the negative behaviors that can also result. And these behaviors really can significantly interfere with consuming adequate nutrition and appropriate mealtimes routines. Not surprising that we found a significant correlation between sensory-based oral motor and GI concerns with greater behavior challenges. Once again, reinforcing that they're probably not the primary challenge, that they're the protection for some of the other difficulties that kids have. So parent-child interactions. Eating is embedded in the parent-child relationship, especially for young children. We provide the food, we model the eating behaviors, we regulate their intake, and it's a significant way that we pass down family and cultural values. So eating is really important to families, potentially even more important than other activities of daily living, which I think needs to be taken into consideration, and partly why we suggest that there's significant stress placed on families when your kid has difficulty eating. And it's not something that you can choose to address once a week. You're forced to do it 7 days a week, 5 to 7 times a day, 365 days a year. So it's an important daily routine. And clearly this plays out and affects family mealtimes. And family mealtimes have been well studied throughout history as some of the benefits for family mealtimes. And we have some emerging studies that have shown that families with kids with autism want the same thing as everybody else, and they want to have an opportunity to experience some of the benefits that family mealtimes have shown. And when we say family mealtimes, I want to be clear that we're trying to acknowledge the diversity in family mealtimes that occur. So historically, we think about a family mealtime sitting down at a table, 5 o'clock, everybody eats. That's not how it usually occurs anymore. And there's a wide diversity in family and mealtimes and how they manifest, and it's important to acknowledge that and then support families in what their family mealtime would look like for them, and allowing them to have the child with autism also participate in that. So we are part of the Autism Spectrum Disorders Feeding and Family Mealtime Project. These are some of the overall aims of our research project. Today I'm going to briefly touch on an evaluation tool that we've created and also an overview of the parent-mediated intervention that we're piloting. So we have developed a feeding assessment for children with autism spectrum disorders based on those 4 constructs that I mentioned before that we think are primary contributors to difficulty with feeding, while also thinking about that they occur in the social context. Most of the feeding assessments on the market right now, often for kids with autism, only focus on the behavior. And while we know that's important, we want to make sure we're thinking about underlying contributors to that behavior. And so we've developed a tool specifically for kids with autism, and we have done our first large pilot of it, and we have 406 families who have participated and filled out the survey. And we've designed the first phase for children ages 2 to 12. We recruited participants through the Interactive Autism Network to distribute the survey. The feeding questions, as I mentioned, were focused on those 4 constructs: sensory, behavior, health, and oral motor. And we also did include a number of other questions that I think will have greater clinical utility, because although it's important we think about identifying and characterizing these underlying constructs that we think contributing to feeding, we want to really make sure that this is useful for families and clinicians in the community and help drive and think about how we want to shape interventions. So there's also a number of questions around family mealtime and history of feeding behaviors that contribute to the assessment as well. And a good example of a question that might contribute to current feeding practices but not be part of the 4 health constructs was kids who maybe had early experiences around eating that were very uncomfortable, such as severe reflux is a real common one. So they never really developed positive eating experiences, and for different reasons that's kind of carried over today. It's important to think about what happened past, even if it's not currently a problem. So looking at just those questions that are in those constructs, we have our first indications are that it does do a pretty good job of thinking about those 4 underlying areas, and the items on the tool are really thinking internal consistency is very high with a 0.87, meaning that all questions seem to really be thinking about or addressing feeding in kids with autism, which is good news. The most important thing I like about this is as we think about those 4 factors that we talked about, the sensory, behavior, oral, motor, and health, the lines in between mean how much do those items relate to each other. So as we talked about before, when we have a kid with feeding problems, usually it isn't all sensory, right? Or usually it's not all oral motor. So this shows us that although there are distinct challenges related to feeding, that they're related to each other. And that's what we wanted to see, that there is some relationship between these. And if you look at these, the highest correlations with medium correlations are between sensory and behavior and oral motor, which is good, important information because it's telling us that when kids have strong underlying oral motor or sensory problems, we're seeing more behaviors, which makes sense, right? So try and make me eat something I don't want to, and I'm going to give you a strong behavioral response. And this is what some of this information is telling us. So the other piece that I wanted to go over quickly is that we're currently piloting a parent-mediated intervention for families with children with autism and feeding challenges. And this developed out of some of our previous pilot work, our previous studies, as well as the literature, thinking about the current parent-mediated interventions that are going on across the country with regards to autism. And most of them are addressing things like social communication and autism symptom severity. And so we wanted to take that model and apply it to thinking about feeding challenges within the context of the home environment. So this was funded as part of an engagement grant with the community. So we had significant stakeholder engagement and collaboration around the development in the intervention, and that included parents of children with autism, Communication Innovations, which is a local therapy clinic, so it had therapists from the community who were currently working on feeding, and then also we had some representatives from the Autism Society of Wisconsin who sat down with us and helped us think about what would a good intervention look like from their different lenses, based on the current interventions that are in Wisconsin and people are receiving, what's working, what's not working. If they could identify the perfect intervention, what would it look like? Talking to families about what are the barriers and facilitators for good interventions, and why would you want to do something versus why wouldn't you want to do it, and how could something be developed and implemented that we could test across families, but yet would be tailored to meet your needs, which is a pretty difficult task in itself. We also had them review parent training modules that we developed and content to give us some feedback on what's relevant and what you need to know and what you not need to know, or what do you want to know and what do you not want to know. So the next step was recruiting families. We currently have 15 families participating throughout Wisconsin with 17 children with autism. 2 families have 2 children with autism. The children have a diagnosis of autism from either the Waisman Center or a community location, and the kids are between 2 to 7 years of age at initiation of the study. Now, as you can imagine, a 2-year-old is somewhat different than a 6-year-old or a 7-year-old. So we really have to think about that within the context of appropriate developmental expectations. Because this is a pilot study and feeding and autism is so highly heterogeneous, the families and the kids with feeding challenges are quite variable as well. So we have everywhere from children who are still primarily taking calories from a bottle to kids who have very, very selected rigid diets. And then the other thing is families needed to participate in a 6-month in-home intervention, which is a lot to ask for families because everybody is so busy and the kids have very, very busy schedules. So considering that they could do that on the evenings, weekends, because we're not saying that we're going to come into the school, we're going to come into the home, we're going to say we need to overlap a time when you're home with your kids and with the family, which is asking a lot because most families, everybody works, and if they're not working, they're fully engaged in other appointments and activities. So we try and recognize that. So the intervention, we do an intake evaluation, and then there's 6 months that include parent training modules, direct intervention, and parent coaching, and then we do a post-evaluation. Training modules are done in the home, some in more formal and some in informal models. There's eight topics that were determined to be relevant, and those are kind of a sampling of the topics that we use. The most important one, at least to mention here, is the first topic is around goal setting. And so a very important piece of our intervention is that we use goal attainment scaling, and so that we're collaborating with families on they set anywhere from 3 to 5 goals, and at the end of a 6-month intervention, this is what they want to achieve. And then we put it in a goal attainment scaling format, and it's a way for us to look across families as far as making progress, but as you can imagine, those goals are very variable depending upon what those family needs are. And we're hoping that we're getting increased family buy-in because they're able to help think about what's important to this family and the feeding challenges here, right? So some families, maybe a really great example of something that's highly variable across families is screen use, okay? So some families really do not want a screen at the table. And other families saying, I don't care if there's a screen at the table, I just want my kid to eat. And so then figuring out how can we make goals around that is a great example of how you might have very variable goals around a similar topic. The next piece is intervention and coaching, and we do everything in-home except for the first and last assessment. We address collaborative goals. As we mentioned, we use the goal attainment scaling. We involve family and caregiver teams, And I bring that up because sometimes there's grandparents or other people in the home that are really instrumental that we need to also include, who are helping feed. The sessions usually start with a check-in. Then we do a warm-up activity that is very different depending on the family and the child's needs. Then we have a snack or a mealtime, and then we do a wrap-up. Parent training is ongoing. Sometimes it occurs in separate sessions and sometimes at the same time. So, preliminary results. We only have 3 families that have completed. So, take that for what it is. So far, all families have met or exceeded over 80% of the goal attainment scores that they've set. It appears that we are getting the most significant progress, and this is coming from the families who have completed, as well as our midpoint assessment at 3 months, that we're getting the most positive changes in family mealtime. So them saying, this is how we'd like family mealtime, let's set a goal around so many minutes at the table, or everybody coming to the table, or everybody eating a similar food at the table. Self-help skills such as utensil use is a really big goal for families. Decreased behaviors, increased general flexibility. So many families say, I don't care if they add 10 foods to their diet, but I want them to taste things, and I want them to be able to make a decision on whether to eat it, not immediately see something new and throw it off the table. So that tasting behavior we've been very successful with. We've had moderate success with introducing developmentally appropriate sized portions of family meal items. So we can get kids to taste them, and we're having moderate success with introducing a new food in an age-appropriate portion size. Because being able to take 5 bites of a new food is fantastic, but that's not the same as being able to put a portion size on your plate and eat it at the family mealtime. Different kinds of goals. So we have a couple minutes for questions. The next step is we'll complete the remaining families. This is really an iterative process because this is a pilot study. So we're hoping to really spend some time with the families at the end thinking about what worked well, what didn't work well. So in the next iteration of the grant, we can put in modifications to continue to meet a variable types of needs. One thing that we're getting, and so we're hopefully going to follow up, is that families are saying, this is going so well with feeding, can we work on potty training? So how can we apply this parent-mediated approach for other activities of daily living in the home context? So thinking about what can we do? Because what we're asking families to do is not necessarily spend an extra hour on feeding a day, but we're saying, okay, let's think about your daily routines and how can we implement strategies so they become part of what you're doing every day. And sometimes those are really simple modifications, and sometimes they require a little bit more work. But thinking about how can we embed within what you're already doing. And so that becomes kind of exciting. And so families are asking about other activities of daily living. So we're hoping to expand and modify this so we could, thinking about maybe rating, here's activities of daily living as a family, what is your top priority right now? And doing it that way versus coming and focusing on feeding. We also have recently gotten funding to add another 10 families to the study, but also add thinking about physiological outcomes, so thinking about heart rate variability that will help us think about the stress that occurs in the parent-child diet, as well as around feeding experiences, because we all know if we're super stressed, it's really hard to engage in calm reciprocal activity and try new things. So if we can think a little bit more about the stress responses of both the parent and child, hopefully it'll provide a platform for even making more progress. So, I know I went over a little bit, but I think hopefully we have time for a couple questions. Yeah.
Do you specifically train your caregivers on the fact that this is not, pardon me. Do you specifically train your caregivers on the fact that this is not behavioral, but that there is a real reason why the children aren't eating the way that parents want them to eat?
Absolutely.
They're not being naughty.
Absolutely.
We do that training. Lovely.
We talk about that a lot, and I think most families, at least that I have currently encountered, already acknowledge that, even if they've been told that by somebody else, that they know their kids aren't being naughty. They know that they're not eating this food because it doesn't feel good, it's uncomfortable, and the kids maybe just aren't able to tell them yet because they're not being naughty. It's hard.
Yeah, cool.
There's a question over here.
Yep.
Hi, my name's Amy.
Hi, Amy.
I had a question. You talked about the constipation,
yes,
and you gave that example about the kid only eating the white crunchy foods.
Yeah.
Why exactly is it a factor? Is it because something you mentioned that it hurts them?
Oh, that's a great question. So you think about if a child's really constipated, or if any of us have been really constipated, your stool gets backed up, right? And you don't feel like eating, and so you're not hungry. And so there's nowhere for the food to go. And sometimes even if the stool's backed up really far, it can even cause other problems like reflux or vomiting or things like that. And then the kids also know that when they eventually have to go stool, that it's uncomfortable and it hurts. So it becomes kind of a cyclical response. And so that's something where we need to make sure that we're using an interprofessional team to address some of these concerns, because none of us are experts in all the areas. So we really need to think about, if there's chronic constipation, how can we help stooling get more regular? Is it a sensory problem? Is it an intolerance? Is it a behavioral problem, that they don't like the way it feels when they poop? So it's hard to talk about feeding without talking about pooping. Mm-hmm.
I think we have one here.
Hi. All of the parts that you said, the oral motor, the health, all of that, yeah, I see in the 3 young adults with autism that we have in our home. But I also see other problems, like decision making being very hard, the executive functioning, because if they're going to choose themselves what to eat, then they actually have to decide what to eat, which seems also very difficult for them. And then come the motor skills with being able to participate in meal preparation, and the trouble initiating. You know, maybe they do have the motor skills. They have decided, okay, I want a bagel with cream cheese. Say they have the motor skills. This is one of the kids who actually has learned how to spread cream cheese on the bagel. But then they have to initiate it. And that can be very hard, you know, getting them started to actually make the bagel. And I'm wondering if you see that those kinds of problems in the younger children too, and or they just come up more in the young adults, and if you have any thoughts about that.
So I think you've hit on 2 really great points that I'm glad you brought up, is that we've primarily looked at feeding in young children. And this is really focused on 2 to 12. I would definitely like to back it down to birth to 2, because I think we can see potentially some disordered feeding patterns early on that might help us think about what's going to unfold later, before children are even really getting a diagnosis of autism spectrum disorder. So that's one piece. And then the other thing is they don't magically disappear at 12. So I think that you've also addressed an area that we'd like to expand on, thinking about adults with feeding challenges. And there's some really interesting things that have kind of unfolded when people were trying to think about eating disorders like anorexia, bulimia, and what's happening is they're getting adults with autism that don't have those kinds of challenges, but just have disordered feeding patterns. And it's different in adults. So some of those things I think you're bringing up right now. Also, when we're talking about the feeding assessment, we're talking about some of these underlying reasons why we think that they're having the disordered feeding. But I think what you're also bringing up is this larger context in which eating occurs, where things like executive functioning, general motor planning are all really important and also need to be addressed beyond just what is actually going in the mouth. So it's kind of multiple steps.
So I'm sorry, for the sake of kind of keeping with our schedule, Karla, are you willing to kind of just hang around just for a little bit? So if you have questions for Karla, you can go up and ask her. Right now, I do want to let everyone else have a break so that we can resume again at 10:30 with Brittany Travers' presentation. So thank you so much, Karla.